from the American Academy of Pediatrics.
Cases of obesity and diabetes are on the rise for children in the United States.
But new policy from the AAP says the low-carb diets so popular with adults are not recommended for kids.
When you're limiting calories by restricting a whole food group, children just may not grow and develop normally. So that would be one concern.
Plus, research in the journal Pediatrics shows promising findings about parenting sets of siblings.
The impacts on the sibling children included improved language development, reduced internalizing problems, and increased dietary diversity.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about low-carb diets for kids with or at risk for diabetes.
I remember having little kids, Joanna, and getting them to eat healthy could be a challenge.
Challenge is a good word, David. The words adventure, guilt, surrender also come to mind. Does it get easier feeding teenagers?
I think it just gets different. Diets are always difficult to regulate for others. But with time and exposure, the kids did start to care about eating fewer processed foods and more fresh ones.
Sometimes, even in pediatrics, certain diets are necessary to keep kids healthy. As a neonatologist, I've taken care of babies with galactosemia and phenylketonuria, and that means families have to take on the job of dietary regulation and restriction early on.
I know in those circumstances, families get a lot of help. I often wonder in diseases like diabetes how much meal management and counseling goes into treating those families. I'm sure pediatric endocrinologists also think a lot about this. I mean, is no sugar or carbohydrate intake the answer to keep these children healthy? Should we all be cutting out carbs?
David, if you want to talk to a pediatric endocrinologist, I have just the person, Dr. Tamara or Tammy Hannon, one of the authors on a new clinical report from the AAP entitled Low-Carbohydrate Diets in Children and Adolescents with or at Risk for Diabetes.
Dr. Hannon is a board-certified pediatric endocrinologist with expertise in youth with obesity, insulin resistance, and diabetes. She's also a professor of pediatrics and the director of the Pediatric Diabetes Program at Riley Hospital for Children in Indiana. Tammy, welcome to the show.
Thank you, David. Thanks for having me.
Let's start with a healthy diet. How many carbohydrates should children be eating, and when is the diet considered to be low in carbs?
Kids should get about half of their calories from carbohydrates. When we look at that on the plate, it's about half of the plate coming from fruits, vegetables, whole grains. And we say that the breakdown is between 10 and 30% of the calories come as protein. About 25 to 35% of the calories come as fat. And then all the rest of that is supplied by carbohydrates. And this is actually generally what children do naturally. When we talk about reducing carbohydrates in the diet, we're talking about eating less than 45% of your calories as carbohydrate. And when you talk about limiting carbohydrates so much that your body is functioning, basically running on fat, that's called the ketogenic diet. And those diets limit carbohydrates to generally less than 20 grams a day, which is about a piece of fruit or a piece of bread. Yeah.
And you mentioned some different carbs, fruit, bread. Are all carbohydrates the same?
No, not all carbohydrates are the same. So carbohydrates come in the forms of processed carbohydrates or whole food carbohydrates. So when we're talking about whole food carbohydrates, we're talking about whole vegetables, fruits, whole grains. So when we talk about grains, we might be talking about beans. We might be talking about whole wheat. And then the more those foods are processed, meaning ground up and made into substances like starches and sugars, and then added back to foods to make a processed food that goes in a package, those carbohydrates are absorbed and metabolized much differently, and they produce a different response in the body. That's why we say that they have different levels of value when it comes to providing good nutrition for a healthy body.
Before we get into a low-carbohydrate diet for management of children and teens with diabetes, I know low-carb diets are super popular for adult weight loss. Is this also a strategy that we use for kids who are at risk of obesity?
Well, there's some concerns with using this as a strategy for weight loss. As you can imagine, anytime you cut out half of the foods that provide calories in the diet, you thereby have to replace those calories with something else. And if you do not replace those calories, you'll likely lose weight. But when we replace carbohydrates, especially carbohydrates from fruits and vegetables, we lose all the nutrients that we only get from fruits and vegetables. And the other thing that happens is, there are only 3 macronutrients: carbohydrate, protein, fat. So protein and fat have to make up the difference. And there are health concerns that come with eating a diet that's loaded in protein and fat as well.
Are there actual harms to children and teens when they're on low carbohydrate diets?
Potentially, yes. So the number one thing that we think about is poor growth and not having enough calories to have normal growth and development. So when you're limiting calories by restricting a whole food group, children just may not grow and develop normally. So that would be one concern. Another concern is that these diets may be nutrient poor in the things that kids need to grow their bones and fully mineralize their bones. So calcium, vitamin D, things that we know set kids up for strong bones throughout their life course. The other thing we get concerned about when you try to follow a restrictive diet is disordered eating patterns. When the body is growing and developing, it has a lot of redundant mechanisms to save itself from starving, to save itself from losing weight. And so one potential side effect of following a restrictive diet is binge eating disorder, or eating disorders that come from using a lot of willpower and restricting the diet so much that mental health disorders and psychological disorders may occur.
And at risk of rehashing information many of our listeners may already know, do you mind giving us a refresher on what exactly eating carbohydrates does to insulin secretion and how that's impaired in type 1 and type 2 diabetes?
Yeah. So when we eat, the food goes into our digestive system and is broken down into carbohydrates, protein, and fat molecules. These are absorbed from the gut into the bloodstream. Okay, fiber is another type of carbohydrate that remains in the gut and is really important for our gut health. So without fiber from those carbohydrates that supply fiber, we're not going to have normal gut health. The carbohydrate that goes into the bloodstream stimulates a hormone response. It stimulates gut hormones, it stimulates pancreatic hormones and other systemic hormones to help to get those macronutrients where they need to go in the body. So sugar cannot stay in the blood. Sugary blood is harmful to our health and to all of our organs. So sugar has to go somewhere. And where it goes is in the liver and in the muscles for energy and in the liver to store as part of glycogen stores. Once glycogen stores are replete, there's no more storage for sugar. Okay, so sugar then is turned into fat by something called de novo lipogenesis and stored as fat. Now, insulin is the hormone that makes all of this go. It's the storage hormone. It's the growth hormone. I mean, there is a hormone called growth hormone, but insulin is an important anabolic growth hormone. So if you don't have insulin, or if insulin isn't acting optimally at the level of the cell or at its receptor, you will not have insulin action and insulin response. So in the case of type 1 diabetes, where you don't have any insulin, you have trouble moving the sugar from the blood into the cells. Okay. Also, you have a liver that is putting out more sugar than it should, because insulin also makes sure that the sugar stays in the cells when it's needed in the cells, right? So if you have type 1 diabetes, you're missing that, and you need to take insulin to do these actions, okay? If you have type 2 diabetes, you have insulin, but you have what's called resistance to insulin at the cells. So you have insulin in the blood, but you might not have enough sugar moving into the cells, and you're not turning off that liver from putting out more sugar into the bloodstream.
So knowing that physiology, would a low carbohydrate diet be just as effective for someone with type 1 versus type 2 diabetes?
Yeah. So before we knew that insulin was the hormone missing in diabetes 100 years ago. So this is 100 years ago that we discovered insulin, not we. The people who discovered insulin. And the treatment for diabetes was basically to limit carbohydrates, and basically the body would starve over time, because even though you're not supplying sugar into the blood supply, without insulin as the storage hormone, your body just keeps on breaking down fat, because it cannot use sugar for energy. It has to use fat for energy. So then people said, well, if I want to break down fat and I don't want to use sugar for energy and I want to lose weight, because I will lose weight if I don't have enough insulin, why don't I just do a low carbohydrate diet? I will get those results. And you will. If you follow a very low carbohydrate diet, you will have lower calories probably, and your body, will use up all of its sugar in the liver. It will make new sugar, but most of the energy will come from the breakdown of fat. When we break down fat, we make a source of energy, and we make a ketone. A ketone is an acid. It makes the blood acidic. So in the case of somebody who doesn't have insulin and they can't stop the production of ketones, the acid in the blood causes severe illness, coma, and death. So if you have insulin and you're on a low-carb diet, you can still make enough insulin to save yourself from dying from ketoacidosis. But a person with type 1 diabetes cannot save themselves from dying from ketoacidosis unless they have insulin. So only following a low carbohydrate diet or a ketogenic diet cannot be an adequate treatment for diabetes. And the theoretical danger of using it to promote ketosis in a person with diabetes is that there's no way to distinguish if that's nutritional ketosis from just not eating carbohydrate, or if it's ketosis because you really don't have enough insulin to prevent the fat from breaking down and making ketones. And so there have been cases of an unfortunate outcome from people with diabetes following a ketogenic diet.
So what sort of diet should people with diabetes, either type 1 or type 2, be following to be their healthiest?
The vast majority of the studies on nutrition and treatment of diabetes, heart disease, diabetes and heart disease go together because diabetes is a risk factor for heart disease. The vast majority of the studies show that a diet that is very rich in whole foods, fruits, vegetables, grains, lean protein, lean dairy, if dairy is included, has the best outcomes for diabetes and cardiovascular disease, which is why the American Diabetes Association and the American Heart Association recommend following those diets. Oftentimes, we in pediatrics recommend using either a plate method or a dietary pattern method to show that to follow a diet that's rich in the most nutritious foods, half of the plate will be vegetables, whole grains, a quarter of the plate would be lean protein, and then you'd have dairy, fat, just being a quarter of it. But less than half of us, I would say the minority of us actually eat this way in real life because processed foods are so convenient.
So I want to follow up on that, Tammy, because I think all of us who've tried counseling families on diet change have found it to be one of the most difficult changes to help families make. Do you have some best practices that we can all adopt when it comes to helping families transition to healthier eating?
I do. I always say first things first. Most kids get most of the added sugar in their diet from drinks. And it is incredibly common for kids to be drinking hundreds of calories a day. And when I'm interviewing patients, I'll say, how are you doing with sugary drinks? Good. I drink almost all water. And I say, good. And then the dietitian might go in, or I might break it down a little further. Well, let's see what you're having for breakfast. Apple juice. Let's see what you're drinking for lunch. Chocolate milk. How about when you get home from school? I might have, a pop or a Capri Sun. Okay. This is not drinking mostly water, right? But people have the intention of drinking mostly water, but it's just so common to have these drinks around. And, there's this conception that juice is fruit and it's healthy. Actually, juice and processed sugars from fruits are quite hard to metabolize in your liver when we have the concentrated sugar from fruit that's in fruit juice. And so I really start with drinks. As sometimes I laugh, I bet I talk about drinks 30 times a day. I always start there. And I have some patients with just amazing results from eliminating those completely from the diet.
And when you're counseling families prone to the development of conditions like obesity or type 2 diabetes, are there universal recommendations you can also give those families just to help with dietary changes in their health?
Yeah. After we get the drinks, we talk about adding fiber for bulk. It's hard to feel full on processed foods unless you eat a lot of calories. And so a lot of people are eating a lot of noodles, a lot of processed carbohydrate, and we don't say stop that, because they're trying to make their budget reach, they're trying to feed their kids, right? And groceries are expensive, right? So we take what they're doing now and we say, Can you add a bag of frozen vegetables to that package of noodles? Can you add more vegetables to the soup, to the, whatever they're making as an entree? How are we going to get the vegetables in there? And they don't have to be just sitting out on the side. They can be in with the entree. How are we going to get the bulk in with the fiber? And that's really going to come with vegetables. I also love beans too, as a way to stretch that and add a lot of nutrition with fiber, because fiber is also so important.
So there's been a lot of food for thought here, Tim.
Yeah.
If you had one takeaway from this clinical report, what would it be?
My takeaway from this clinical report is we don't need extreme diets to improve the outcomes from diabetes care or with diabetes prevention or with the treatment of kids who are at risk for these diseases. I think what we need is a society who supports the recommended diet that includes carbohydrates, proteins, and fats. Right now, we have a society that supports too much sugar, too much added sugar. This isn't family's fault. This isn't kids' fault. It's definitely not kids' fault. And the takeaway that I have is we don't need to go to the extreme to improve kids' health, because food should be medicine. Food should be really there to nurture our kids. Kids should enjoy the food. And I really think that that's the takeaway, that there are some things that we can do as a society to make it such that kids and families don't feel like they need to do extreme things to get best health outcomes. And I just want to emphasize one more thing. Some children eat the majority of their calories at school and away from home. And as a society, I think it's really important to provide high quality nutrition and advocate for policies to protect and strengthen federal nutrition programs, including school meal programs, to ensure that all kids, regardless of their circumstances, have access to high quality nutrition.
Such important advocacy. Dr. Tammy Hannon, thank you so much for joining us today.
Thank you.
To read the clinical report, Low Carbohydrate Diets in Children and Adolescents with or at Risk for Diabetes, visit our website at aap.org/podcast.
Coming up, we'll look at how parenting one child can have spillover effects for their siblings.
I often feel like my kids, Mira and Simon, are so similar because they're less than 2 years apart. But now Mira, being close to 6 years old, seems so much bigger. And I wonder if my parenting of her should be different from my parenting of Simon.
When you say parenting, what do you mean? How you interact with her in terms of the tasks you ask her to do or the words you use? I'm just curious because with my 5 kids, I'm not sure I knew what I was doing.
Yeah, it's hard when your kids have such different personalities to know if the same parenting tactics will help with their development in tandem. And few studies of parenting interventions look outside of the child the actual intervention is focused on.
Well, until now, Pediatrics just published a paper, Effects of a Parenting and Nutrition Intervention on Siblings, a cluster RCT. This could be the paper you were looking for, Joanna, and we have the lead author, Joshua Jeong, here to talk about it.
Josh is a doctor of science and a Rollins assistant professor in global health at Emory University. He studies parenting, child development, and the role of fathers in promoting development in low-resource settings. Josh, welcome to the show.
Hi, thanks, Joanna and David, for having me.
Thank you for being here. And this study, it was actually done in Tanzania. Can you help our listeners understand what a typical family structure looks like in Tanzania?
Of course. So Tanzania is a country in East Africa, and according to national data in Tanzania, about 75% of children under the age of 2 live with both their biological mother and father. So while we may think that it's in a different part of the world or family structures may be really strikingly different, that statistic or the demographic is somewhat comparable to the US, at least, where most children are living with both a mother and father. But what's a little bit different is that households are larger than typical households in the state. So in our data from the effects study, which we'll talk more about, on average, there were 7 people in a given household, which is larger than my family, at least here. And families also have multiple children. So on average, households in Tanzania at a national level have 5 children under the age of 18 years. And that's the average. And then when looking just at kids under the age of 5, on average, households in Tanzania have 2 kids that are under the age of 5. So suggesting just larger family sizes than at least my family and what I know of the families in the US.
Well, in the study, and you already mentioned the word effects, which is what you named the study. It stands for Engaging Fathers for Effective Care for Nutrition and Development Study. Can you describe a little bit the aims and then what outcomes you were looking for in the effects study?
Sure. So effects was a 5-arm cluster randomized controlled trial where we tested 4 different interventions against the 5th arm being a standard of care control. So we had one intervention that was a nutrition intervention with just mothers, a second intervention that was a nutrition intervention with both the mother and the father or couples, the third intervention, which combined both nutrition and parenting messages and deliver that to mothers, and the fourth intervention combined nutrition and parenting messages and deliver that to both the mother and father or couples. And so the aim of effects was to see what are the impacts of engaging not just the mother, but also the father on child and family outcomes, but also testing what does it look like when we combine parenting compared to a nutrition-only intervention on child and parent outcomes. So for the outcomes that we measured in effects, they can be thought about in terms of 3 different levels. Maternal outcomes, or outcomes about the mother's nutrition knowledge and practices, or parenting knowledge and practices, or their gender attitudes. At the father level, those same outcomes. So what do fathers know about nutrition? What are they doing in terms of their parenting? And then the third bucket being child level outcomes. So we enrolled one child who was under the age of 2 years in a family and measured their nutrition outcomes and their development outcomes. The intervention was 12 months and they were measured at baseline. So before the intervention, halfway through the intervention, and then after the intervention ended.
You mentioned that you were assessing child development. What kind of scales did your study use?
So for child development, we use the Bailey scales of infant and toddler development. This is considered a gold standard measure where a assessor or a research assistant, in our case in Tanzania, who was from the community, went to the households and observed the child for their skills in cognitive development, language development, and motor development. And these assessments were about 90 minutes to 2 hours long, so quite intensive. And then in addition to child development, we measured child nutritional outcomes. So in the main effects study, the primary nutrition outcome was children's dietary diversity, so the variety of foods that they ate in the past 24 hours.
And this study is really ambitious because you evaluated both the child being studied and their sibling. So can you talk about how hard that was to do and how you were able to collect that data on the sibling?
Yeah, that was quite intensive, I would say, first and foremost in terms of resources and just needing to get additional funding for this sub-study. But what made it maybe easier than you may imagine or what might be in your mind is that we had these 2 data collection efforts and did them separately. So first, we went to the households to measure the outcomes of the main child enrolled from the beginning in the effects intervention. And then several months later, once the main outcomes were collected from the index child, we went back to all the households to just focus on assessing the sibling child outcomes. And so then we used a different set of tools because the children were of a different age or the sibling children spanned a broader age range. And we were able to focus the training on the sibling child evaluations. So yeah, they were 2 separate exercises.
And with these exercises, what did you find when you instituted these effects interventions? Did the benefits spill over to the sibling or only help the child for whom the research was targeted?
This is the most exciting part of the conversation because we were able to find really nice and notable spillover effects on the sibling children. So in the main paper and the main trial for the index children, we find improvements in those kids' cognitive and language skills as well as their nutritional outcomes. And that is great and in line with the original conceptualization and hypotheses that we designed the trial for from the outset. But then for the sibling sub-study, this was not something that we, from the beginning of the study design, had planned to do. It was only as we started rolling out the study and reflecting on the emerging results at baseline and midline did we decide to include this component. And the main limitation was that we were restricted in terms of our sample to those who are already included in the trial. But even so, even though we weren't adequately set up and powered to measure outcomes or to detect small differences in the sibling child outcomes, we were still able to find meaningful improvement. So the impacts on the sibling children included improved language development, reduced internalizing problems, and increased dietary diversity. And these effect sizes seen with the sibling children were quite comparable to the impacts of the main intervention on the index children who were originally enrolled in the trial.
Wow, that is really exciting, actually. And do you think it's translatable to other communities outside of the one you studied in Tanzania?
That's a great question. And I think one area for more research in this field, because yes, there are so many interventions in low resource settings around the world that are aiming to support caregivers. We know that caregivers and parents especially are one of the most important people in the lives of young children. And so helping them with their stress, increasing their understanding about child development milestones and age-appropriate play and communication activities that they can do is a really impactful approach for improving the lives of children. And in low resource settings, like we started out our conversation, families often have multiple children. And it's not just a single child that a caregiver is providing love and support for, but often multiple. And so in these settings like Tanzania and elsewhere, where there are multiple children, these types of interventions, we're underestimating the potential and the impacts of these interventions by not studying and then trying to more actively improve those mechanisms for reaching multiple children within the family.
Well, this seems like a real leap forward for either researchers hoping to build on this type of work or practitioners who are hoping to sort of leverage this new information. Do you have any last takeaways, particularly for those working in low-resourced settings?
Yeah, I think like we started, or like you both had started the conversation today, this is not really that surprising, right? We know that we as people, we caregivers, family members, are never doing something or are in relationship with someone in isolation, that we are connected. And so I think this result highlights how when we do research, when we try to think about the impacts of caregiving on children, we need to consider more broadly the family environment. One really important thing I want to highlight, which we talk about in the paper, is how these results come from an intervention where both the mother and father were involved. And so to what extent is this co-parenting or the engagement of two parents contributing to some of these spillover effects is a question that I'd love more people to study, and that is very relevant for practitioners too, in thinking about not just empowering one parent, but engaging multiple people in the child's life.
Josh, thank you for reminding us how interconnected we all are, and thank you so much for joining us today.
Thank you.
To read the paper, Parenting and Nutrition Intervention on Siblings, a Cluster RCT, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, mine is to say follow-up. Several weeks ago, I talked about how my wife, Christy, had surgery on her tibia and could not get off the couch or walk around and all the help we got. But now, just this week, she's walking the dogs around the block with me. And yesterday, 2 blocks. So I think we're going to be strolling hand in hand through the National Conference and Exhibition Hall. At least that's our hope. So here we go.
Yay! Oh, I cannot wait for the National Conference and Exhibition. It's going to be so much fun. I think my say is that I am entering my 3rd trimester of pregnancy. So I'm definitively look pregnant. It's okay to come up to me and ask me how it's going. And I'm really looking forward to seeing everybody in D.C.
Oh, I cannot wait to see you there. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer. And Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about hearing assessment in infants, children, and adolescents.
We'll speak with one author of a new clinical report, Dr. Julia Hecht. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.